in India because cancer cervix is one of the most common, that is second most common malignancy in women in India. We do radical hysterectomy routinely, approximately 8 to 10 radical hysterectomies I do in a month. It's a high volume center. Greetings from Omega Hospital, Kurnool. We've been here for past 7 years and we have treated more than 1 lakh of cancer patients, more than 10,000 complex cancer surgeries in the past 7 years. And we thank the support of the local fraternity for this endeavor. So classically, radical hysterectomy is done for cancer cervix, early stages, invasive stage A1, A2, B1, and some of the selected B2. Bulky tumors which are more than 4 centimeters, even if there is no parametric involvement, sometimes do require adjuvant radiation. So we do not want patient to have involvement. Cases are subjected to surgery. Invasive vaginal cancer, though it's a classical non-surgical disease, but some very limited upper third vaginal involvement, especially posterior fawning, stage 1 and 2, do go for surgery, that is radical hysterectomy. Endometrial carcinoma, if endometrium, body as well as isthmus and cervix stroma is involved, we take them up for radical hysterectomy. Disease that is persistent after radiation is also subjected to radical hysterectomy. Various classifications are there. I do not want to go into details. Basically, we use Piver et al. Classification, type 2, type 3. So basically, type 3 is what we do. Principle is you ligate the uterines at their origin, lateralize the ureters in their course to get at least 2 to 3 centimeters of parametrium and remove the upper 1/3 of vagina. That's the philosophy of removing the entire disease in radical hysterectomy. So basically, these pictures, you have a pointer? So in these pictures, you can see the parametrium, the difference between the subtotal, total, and radical hysterectomy. And if you see a radical hysterectomy, that is a, okay, sorry, there's no point, LED won't work. There's a red line, which removes the upper 1/3 of the vagina as well as this thing. In addition to radical hysterectomy, we add lymph node dissection, which includes the removal of external iliac and obturator group of lymph nodes. The boundaries of this being on the lateral side, you have genitofemoral nerve. On the medial side, you have internal iliac arteries. Dorsally, you have obturator nerve. And ventrally, on the lower side, you have the circumflex external iliac vessels. So entire pocket of fibrofatty tissue and lymph nodes in these boundaries is removed in toto and sent for histopathology. So classical approach is open. Either you do a fan and steel incision or midline vertical depending on the patient's habitus. My preference is midline vertical. This is because the exposure, as well as if you find any untoward findings in your field, the flexibility is there with the vertical incision rather than a fan and steel incision, though it's cosmetically acceptable by the patient. And you have minimally invasive approaches, laparoscopy and robotic. So the evidence is now, earlier it was minimally invasive, yes you should do, but now early disease less than 2 centimeters, open has taken little bit edge over the minimally invasive in this entity alone. Rest of the entities, minimally invasive is equivalent and sometimes superior. But in surgery for uterine cancer, radical hysterectomy, early stages, open surgery is right now the gold standard. Pendulum may swing back to minimally invasive. Though people practice both, it is doable and oncologically equivalent in both approaches. So basically, you need to know anatomy well, like any surgery in oncology. You have complex organs as well as tissues, compact space. So you have McInrod's ligaments, you have uterosacrals, you have rectovaginal and rectouterine ligaments and vesicouterine ligaments. Paravesical, pararectal spaces are available, and you have autonomic nerves to preserve, ureters to preserve. So all these anatomy in the compact space makes it a difficult, challenging operation, and any bleeding in this field again will obscure the vision and further pose difficulties. In addition to anatomy, now you have something called embryology also is coming up in a way in our surgeries. We have evolved over the period. And embryology has given way to a different entity now called total mesometric resection, radical hysterectomy now. In addition to a routine surgery, even facial planes are also need to be respected looking at the embryology. So equivalence is there between surgery and radiation in early disease. But we tend to prefer surgery because this is a disease of the young. 1 decade, like around 30 to 40 years old, and basically ovarian function and sexual function needs to be preserved, which is done very well by surgery rather than radiotherapy. So radiotherapy is little lower in the quality of life compared to surgery in that aspect. So what are the salient steps in the surgery? Once you expose with the midline vertical incision, You divide the round ligaments, you divide the infundibulopelvic. But infundibulopelvic are not divided in every patient. If it is more than 40 years old, you want to remove the ovaries in addition to hysterectomy, you do that. But younger patients, we tend to preserve ovaries, so you don't divide the infundibulopelvics in them. Then dissect those pararectal, paravesical spaces, isolate the ureters, lateralize the ureters, and ligate the uterine arteries at their origin. Dissect the tunnels again further so that they get displaced laterally, expose more of the parametrium and paracolpium. Dissect the rectovaginal space, separate the rectum from the vagina, excise the uterosacrals, and finally removal of the parametrial cuff and vaginal cuff. That completes your radical hysterectomy, and later you do bilateral pelvic lymph node dissection. So this is what I see. The first picture you can see, we are digging at the uterine arteries, that ureteric tunnel. You have a water under the bridge, basically uterine artery over and ureter below, that dissected. Clamping of the uterine vessels as laterally at the origin possible to expose the ureter in the middle, deroof the ureter basically. After that, you can see that one thumb's artery forceps, I am looking at the ureter, and the Kelly's clamp is pointing towards the vagina. So the distance between the ureter as well as the Kelly clamp is more than 2 to 3 centimeters. That much of parametrium is available for you because you have lateralized ureters. Then rectovaginal space, rectum is separated. You can see the uterosacrals taut, lined up, or nicely visible, and they are clamped as close to the rectum as possible and mindful of not injuring the rectum. Once that is done, this parametrial tissue is clamped, cut, transfixed, because multiple vessels are there. You can use different energy sources. You can use ligashore, or you can use harmonic for sealing of these vessels and parametrial tissue. Once that is done, next you go to the vaginal cuff. You can see the distance of vagina, more than 1/3 of the vagina is separated from the tumor, and clamp is done. After cutting the vagina, vault is closed. This is the pelvic lymph node dissection template. Exposure first of the entire boundaries are very clear. You can see the marking of the boundaries, okay, and then after removal of the fibrofatty tissue, this is what it looks like after removal completely. Vault in the middle, ureters, both the pelvic lymph node dissection. Let's get to the video. This is the exposure, retraction with Balfour's retractor, holding of the uterus completely so that it is stable, it is good for maneuver. Now we are cutting the round ligaments. Broad ligament leaf is opened, both cranially and caudally. To my left is the caudal end, to my right is the cranial end. That's what you'll see, the opposite there. So once both the leaves of broad ligament is opened, you have the loose areolar tissue there, and you have to keep dissecting with Kelly clamps to develop. These are called pararectal and paravesical space. This is the pararectal space. Once you develop this space, ureter also becomes visible there, and that is the paravesical anteriorly that is being developed there. These spaces have to be developed before, and you have to palpate and see if you have any tumor deposit or if the thickening of those ligaments there. That subtly, this is the infundibulopelvic ligament that is being ligated between clamps. Once that is done, some people remove the ovaries separately, or you can tie them to the cockers that are holding the uterus. This is done on the opposite side. You have finished the right side, now you are on the left side. Similarly, opening of the broad ligament anterior and posterior leaves, that can be extended caudally and cranially. Caudally, you will go to the uterovesical fold of the peritoneum. Cranially, you will reach the infundibulopelvic ligament. Same spaces are being developed here, pararectal and paravesical. That gives you the idea that ureter is exposed there. You can see the ureter that has come visible. This is the infundibulopelvic ligament that is being held. Okay, that is a ureter, yellow line. Once that is done, you will go to the anterior side to separate the bladder and push the bladder beyond the cervix and vagina. Either you can use scissors, dissection, classical conventional scissors, or cautery. Idea is not to injure. If you are doing it minimally invasive, once you open the fold of peritoneum, carbon dioxide and the pressure itself will create the planes into the loose areolar tissue, separates the bladder from the cervix and vagina itself. This you have to separate it until you reach the growth, as well as go beyond the growth up to 2 to 3 centimeters of the vagina. That can be easily done. Intraoperatively, if you're finding it difficult and if you feel the tumor has come out anteriorly, that means you've not selected the right patient. So very rarely that you will abandon a procedure for inoperability. Okay, fine. Once this is separated, we will come to lateralization of the ureters. I'm holding the ureter and separating it laterally. Make sure you do not disturb the adventitial tissue as with the fibrofatty tissue around the ureter. Do not bear it. And laterally, you do not bear it all around. Only on the medial side, inferiorly and superiorly, you will bear it. But laterally, you leave behind certain attachments so that vascularity is preserved. Once that is lateralized, you have to create the tunnel with Kelly's forceps. Okay, that is a tunnel that is being created. Once that is done, we have cut open the uterine vessels. That's what you're seeing. Ureter course. Okay. Yeah. And after that, you have to cut the fibers that attach. Basically, it's called vesico-vaginal or vesico-cervical uterine ligament. You cut it open so that ureter is exposed more. That is the ureter that is being exposed. Completely separate it, roll it out to expose more of parametrium. Once that is done, this is being done on the opposite side. Similar procedure, same procedure is being done on the opposite side. Lateralization, and this ureter has to be exposed up till the bifurcation of the external iliacs, common iliac, sorry. Again, tunnel. This is the tunnel that is being created this side. Uterine vessel is separated from the ureter below, clamped. You can see very clearly that I am going up to the origin. Now this clamp is going up to the origin of the uterine vessel, right? Okay. Once that is cut open, we have completely, that is the entire ureter. Further tissue, same vesico-uterine, part of the vesico-uterine ligament is being cut so that ureters further are exposed completely and rolled away from the paracordium to prevent further injury or damage. Once that is done, next we'll go to the posterior. This is separation of the rectum from the vagina. Recto-vaginal ligament is cut. It's not visible now. After that is done, you will separate the intrasacrals. It's a little difficult to videotape in open surgery. It's easier when doing minimally invasive. This is clamping of the parametrium. You can see that almost 3 centimeters of parametrium is there in the clamp that is being cut. After that, you can transfix it with the vicryl to achieve hemostasis. Right? This is what we have done on the opposite side completely. Next, we'll come to transection of the vaginal cuff. You clamp with a Vadheim's clamp. This is what is being cut, held with Kelly's forceps. Specimen is being delivered. So radical hysterectomy specimen is being delivered with the last cut of the vaginal cuff, which is almost 3 centimeters below the tumor. The vault is closed. This is the closure of the vault. Either you can use interrupted 2 layers or interrupted 1 layer or continuous 2 layers. Doesn't matter. Whatever you're used to, giving you the best result, keep doing that. This is the closure of the vault. Once that is done, we go for a pelvic lymph node dissection. That is a genitofemoral now, that whitish structure that is being seen at the suction tip. That's a lateral margin. People use scissors, slow dissection, bipolar forceps, monocolor cautery. Whatever you use, you have to be very mindful of the external iliac vessels and nerves there. And small vessels supplying the enlarged nodes also can give you troublesome bleeders. And if you identify a large size lymph node, you have to clip it instead of leaving it open, because post-operatively you'll have lymphocele as well as sometimes pressure on the vessels can give deep vein thrombosis also. So better to, this is the completed dissection. This is the completed dissection on the opposite side. Once that is done, drain is placed and wound is closed in layers. This is the specimen of the radical hysterectomy. This is the cut open specimen to show everything. So there are last two slides I'll finish. Now, in addition to routine radical hysterectomy that we've been doing, you have 3 more different things that have come up. Once I just spoke about looking at embryonal development of the organs. Based on that, we are developing the surgical techniques. If you see here, this is the cervix and this is the parametrium here. So classically, when we do radical hysterectomy, cervix with the parametrium is removed. And if you keep in mind the embryonal origin and the facial planes, the orange structure that's called the mesometrial structure, that is also is now included. So entire mesometrial structure from here, being mindful of the origin and the facial planes, is removed totally. This is basically to improvise upon what we have already achieved. We're just trying to improve the survival rates, improving the quality of life, and do little more after understanding our knowledge about the disease, the development, everything, so that we can give better results oncologically. So this is another thing, fertility preserving surgery, radical trachelectomy, either minimally invasive or vaginal or abdominal, you can do for preservation of fertility. This is done only for a very small lesion, early, less than 2 centimeters. So carefully selected patients, you can go for radical trachelectomy rather than radical hysterectomy. And nerve sparing radical hysterectomy is being in vogue. We do practice that basically to preserve the bladder functioning as well as vaginal functioning, improves the quality of life, prevents the atony or retention of the urine or dissatisfaction during sexual activities. So vaginal function as well as urinary bladder function is preserved by preserving the autonomic branches that are supplying to the vagina and bladder, and only cut those branches that are supplying the uterus. So there is another thing called fluorescence guided surgery. It is now being utilized extensively in all fields of surgery, especially in oncology. Identify the vital structures, sometimes identify the vascularity and also tumor tissue. So you inject indocyanine green into the catheter that is placed in the ureters via cystoscope, and use a special light and special camera so that fluorescence is given by the drug indocyanine green, and ureters are lighted up like green roadways. You can see them just before starting the surgery. You do this, you are very, very clear about where the ureters are, where the tumor is, where your anatomy is. So little more safety. It is basically, it's giving you a little more safety for your surgery. So this is what is being recommended. Hopefully we want to bring this surgery to Kurnool too in a year or so. And this is sentinel lymph node biopsy for doing less. It's already being done in breast cancers, cutaneous malignancies and other things. So cervical cancer and endometrial cancer is not an exception. Instead of doing an extensive lymphadenectomy for early stage disease where you may not find disease, and post lymphadenectomy definitely lymphoceles, DVT complications as well as infective complications are there, pedal edema, some kind of decrease in quality of life. You want to improve, indocyanine green is injected into the cervix either at 2 places or 4 places, and you see the lighted up green channels of the lymphatics as well as lymph node. Those are identified, sent for frozen section. If they're positive, you proceed with lymphadenectomy. If they're negative, you avoid lymphadenectomy, and thereby reducing the morbidity of the surgery. Thank you for your patient listening and the opportunity.
Thank you, Dr. Ravindra Baabu, for that. Thank you, Dr. Ravindra Baabu, for the enlightening presentation. May I ask what is the practice in your institute after this LACC trial you were talking about? Is it a minimal invasive approach for less than 2 centimeters or a open thing?
Usually less than 2 centimeters.
Minimal invasive approach for less than 2 centimeters or a open thing?
Usually less than 2 centimeters now recommended to go open. More than 2, yes, you do select. Sometimes you have to have an advantage of minimal invasive, but not in every case. So in cervix, you have seen the pendulum swing back to open. We are doing this thing open. For minimal invasive, less in our scenario because most of the times we have certain constraints. That is another reason. But you can still go for minimal invasive even early, provided patient accepts that, study data, you be open, you be frank, discuss with them. If they accept, go for minimal invasive also.
Because after this LACC trial, even NCCN has changed its guidelines to open. So
yes,
do you think any medical legal issues will be there?
No, see, all this is basically how frank you are with your patient, how open you are. You discuss with them, give options, give the evidence, let them read the evidence and take them into confidence. Most of the issues are resolved with this matter, if you are open about it.
Thank you, sir.
Yeah.